I guess that's why it's triple positive, but we're also in a little bit of a data-free zone in that there have never been a specific trials that have been directed against triple positive breast cancer. So in that context, let's have some lively discussion. Let's keep our minds open as to, how addicted our cancers, these cancers really are to one or the other pathway, and think of ways in which we can escalate and de-escalate. My name is Jenny Chang. I'm from Houston Methodist Cancer Center, and the first talk that we have is a tape talk by Sarah, who basically, they did it the other way around. They switched.
Yeah, I think so.
I do apologize. They switched things around. I do apologize. So the very first talk is actually from Dr. Harbeck from University of Munich, who will be talking about escalation and de-escalation, titrating the right regimen in early stage HER2 positive breast cancer. So, Dr. Harbeck.
So thank you, Jenny, dear colleagues. It's great to see some of you here in the hall, the rest virtually. It's my pleasure to start this session off with de-escalating and escalating therapy, titrating the right regimen for the individual patient. Here are my disclosures. What I'm going to be talking about in the next about 30 minutes is where we are right now with regard to escalation and de-escalation, what routes we're currently exploring, and where do we want to go. And Jenny, there are some talks, some studies on triple positive, but you're right, none of them have been practice changing so far, and so it's very difficult to tease out the data for triple positive compared to all of HER2 positive early breast cancer. So actually, we're quite standardized around the world with regard to HER2 positive early breast cancer. We have a small group where we don't use a neoadjuvant therapy based on serotolainase data, and then the majority of patients today receives neoadjuvant therapy, and then we escalate or de-escalate based on the PCR status. When we look now where we can de-escalate or escalate even more, I think it's important to see where we are today and what we've learned about these two different luminal and non-luminal HER2-positive early breast cancer. So if you look at the survival data, and this is from the Munich Cancer Registry, you see that the hormone receptor positive HER2-positive tumors do slightly better here. This is the time to first metastasis, and this is the relative survival, but it's not by much, and they're sort of, the extremes are luminal A and triple negative. When we look at the effect of anti-HER2 therapy, and this is from the very recent Oxford overview analysis with regard to trastuzumab efficacy, you can see that the efficacy of trastuzumab is actually quite similar in ER-negative and ER-positive HER2-positive disease, but what we see is that the events come at different time points, whereas in the ER-negative situation, you sort of have most of the events coming in the first 5 years, and then there is really not much happening anymore. And in ER-positive, we have events coming in all the time until 10 or 15 years out. It's similar like in luminal-like disease, so I think we have to keep that in mind when we talk to our patients about follow-up care, but also when we design clinical trials, and that these facts impact clinical trial designs and clinical trial results. We saw recently at the Affinity trial where we had different outcomes after 3 and after 6 years regarding hormone receptor status. The other thing we need to keep in mind is that there is less PCR with ER-positive disease, and we see here from the very small Trifina trial, which had a completely different endpoint, cardiac toxicity. But you can see here that for all of these very contemporary regimens, be it with or without anthracyclines, ER-positive disease has less PCR than ER-negative disease. And on the right-hand side, you see from the FDA meta-analysis that the effect of PCR status on outcome is not as pronounced in HER2-positive, hormone receptor-positive disease as it is in the hormone receptor-negative disease. And in our clinical algorithms, even today, we already de-escalate and escalate. So I put in blue where we de-escalate and in red where we escalate, and I'm just going to show this to you in the next couple of slides. So the first part of de-escalation we do at the tumor board right in the beginning, when we sort of see whether we really need neoadjuvant therapy, and then we look at the data from the Nadia Harbeck, the APT trial, and here we see that after in 400 patients, only 1% of distant recurrences if you operate first in tumors up to 2 centimeters node negative, and then give 12 weeks of paclitaxel with trastuzumab. And the original trial also had patients with up to 3 centimeter tumor size, but I think most guidelines sort of restrict the recommendations to 2 centimeters because there was only 10% of the patients really having more tumors larger than 2 centimeters. So the data validity is not as secure. But if you look at hormone receptor positive and hormone receptor negative, both of them do really, really well. The other part of de-escalation, there's a bit of a controversy between the US and the rest of the world, if you want. It's about the anthracycline. So a couple of years ago at ASCO, we saw the TRAIN-2 trial from our Dutch colleagues, where we saw that the PCR as well as event-free survival was quite similar between an anthracycline-containing and an anthracycline-free regimen with dual HER2 blockade, if you want optimal HER2 blockade with trastuzumab and pertuzumab. So this trial has been criticized a little bit because it's not so many patients, slightly over 400, and the regimen the Dutch colleagues used is something that we haven't used in clinical practice so far. It's a very long regimen with weekly paclitaxel and carboplatin, but on the other hand, that gave them the opportunity to just exchange 3 cycles with the anthracycline. So for the trial purpose, it was very, very good. And there's other trials like the old BCRG-06 trial that basically showed the same, that the efficacy with an anti-HER2 therapy is quite similar between anthracycline-containing, anthracycline-free regimen. And Dutch colleagues saw less cardiac toxicity without the anthracyclines, and there was also 2 acute leukemia cases in the anthracycline arm. So in the US, the NCCN took this up, and sort of the preferred regimens, if you want, in HER2 positive do not contain anthracyclines anymore for the majority of the patients. Whereas if you look at the St. Gallen consensus earlier this year in Vienna, the majority of the panelists sort of said we still want these anthracyclines. So there's a bit of a debate going on internationally, but with regard to hormone receptor status, there is no differential data there. The second question is, does everybody really need dual HER2 blockade? And here we know from the affinity trial, from the 6-year follow-up, which was recently published, that the node-positive patients do benefit if we give 1 year of dual HER2 blockade with trastuzumab and pertuzumab, whereas the node-negative patients do not benefit from that treatment escalation. And with regard to hormone receptor status, we see that both hormone receptor positive and hormone receptor negative disease do benefit. And that was different in the first analysis, but I showed you that you have to wait longer in the luminal HER2 positive cohort to really see an impact there. Then we can talk about whether the route of administration, whether we can de-escalate here. And here we see data from the subcutaneous administration of trastuzumab and pertuzumab from the Federica trial, that the efficacy is the same between IV and SC pertuzumab and trastuzumab. In the Francesca trial showed very nicely that patients who experience both administration routes prefer the subcutaneous route. So whether that is utilized in clinical practice as a de-escalation approach, a patient-friendly approach, obviously depends on where you practice, whether in a rural area, how long patients need to come to the hospital, whether the chairs in the IV unit are scarce, and last but not least also on the reimbursement and what role biosimilars play in the setting you're practicing. The last question I want to address is whether there is an optimal duration for anti-HER2 therapy. And here we saw data recently at the ESMO from Helena Earle and her group, who had a nice meta-analysis on all these trials, longer versus shorter anti-HER2 therapy. And they were able to show that if you compare 12 to 6 months, there is non-inferiority in this meta-analysis, but 9 weeks is not enough compared to 12 months. So the authors concluded that this may empower personalized patient choice, and that the additional 6 months provide only marginal benefits. So there is a bit of a choice for patients and their teams. But if you go into detail into these studies, and this is from a very nice discussion Dr. Picard gave at ASCO for the Persephone trial, which is actually the only trial that as a single trial reached non-inferiority for 6 months versus 12 months. She very rightly pointed out that there are clinically relevant subgroups where 12 months may be better, and these are the ones with the neoadjuvant chemo, with the concomitant chemotherapy and trastuzumab. And so this is quite clinically relevant, and we haven't seen those subgroup analysis from the meta-analysis so far. So I would like to argue that maybe this is not the right question to ask in unselected populations, but right now the question would be in patients with PCR, do we really need to do one whole year? And here, this cannot help us, but Dr. Earl said that they're already doing such a trial in the UK, sort of as a APT approach, a one-arm trial with a statistical endpoint. So let's look at the other side of the coin, look at the therapy escalation, and here is from the Catherine trial regarding TDM1 use. So the patient and disease characteristics did not differ between HR positive and HR negative disease, and the outcome also was quite similar with the effect, the magnitude of benefit from TDM1 was quite similar, independent of the hormone receptor status, but the hormone receptor positive population, they did better as a whole, as you can see here, but this is very short follow-up, and we've seen what happened in the affinity trial, so I think we just have to wait longer to have the full extent, but there is no indication that the benefit from TDM1 here in escalating is differential. Also, the safety was the same between hormone receptor positive and hormone receptor negative populations, and about almost all of the patients with HR positive disease received endocrine therapy here. The other way we can escalate is go even beyond that, beyond this 1 year, is with neratinib based on the Extenet trial. And in Europe, we have an indication for neratinib in hormone receptor positive patients within 1 year of adjuvant trastuzumab-based therapy. And you can see here that the impact of an additional year of neratinib is about 5% on IDFS and DDFS. It's about 2% on overall survival, and there's very interesting data that numerically there is less CNS events in the neratinib group versus the placebo group. The benefit, the magnitude of benefit from neratinib is even greater in the patients with non-PCR, as you can see here, even with the benefit 9% of regarding overall survival, but we have to be very careful here. This is exploratory subgroup analysis, and also we don't know for our patients today with modern anti-HER2 therapy like dual HER2 blockade and TDM1 what the actual magnitude of benefit would be with neratinib, and we have to tell this to our patients. But we were kind of pleasantly surprised in the German-speaking countries when we put up the Eleanor trial, sort of registering how patients did and looking at side effect management in patients who fitted the EMA indication. And this trial was really recruiting very well. Now we have over 200 patients in there, and we're sort of looking at eHealth Kankado system with regard to side effect management. And if you're interested to see the first interim analysis, please come and look at the poster of my colleague Diana Lüftner. So in summary, what is our current clinical practice? So I think we already do therapy individualization, but it's done independent of the hormone receptor status. We have de-escalation in place with regard to these very small tumors where we use primary surgery. We do anthracycline-free chemotherapy in a lot of our patients already, and the optimal duration, I think, is still 1 year, but they may be disputed, but I think 6 months may be sufficient for selected patients, and my personal gut feeling would be that those are the patients with PCR. Subcutaneous antibody application is something that is very good, in particular during a pandemic, but definitely depends on the therapeutic setting you're practicing in. And escalation is already standard of care. We escalate to TDM1 based on non-PCR. And also we can escalate endocrine therapy if you look at the premenopausal patients. We're going to be talking at this meeting more about this. So with regard to escalation, de-escalation, what kind of clinical trials do we have? What's the trial evidence, and there's only very few trials that actually look specifically, and that was what our chairperson was pointing out to, that specifically in the hormone receptor positive situation, unfortunately. So with regard to therapy escalation, the list is very short. If you look at what's happening in HR plus disease, we have 3 trials, and there's probably more. I just picked the ones that I was aware of from a German point of view, where we add atezolizumab to TDM1, where we add tucatinib to TDM1, or where we try to replace TDM1 with a 3rd generation ADC. And there's only one trial, a major global trial, that is actually doing something specifically in HR positive disease. That's the e-monarch-HER trial, sort of using the monarchy approach in HER2 positive, high-risk hormone receptor positive population. And this trial includes patients that come down the adjuvant route of therapy with primary surgery, or the neoadjuvant approach, and then non-PCR and TDM1. So very interesting approach, and I personally, my guess is this is a low-hanging fruit, because this will definitely add to the efficacy of the endocrine therapy in this setting. So with regard to de-escalation, there's basically 2 pathways that are being pursued. One is based on biomarkers, and the other one is based on early response assessment. And first, before we talk about de-escalation in more detail, we have to just state that there is good evidence that PCR obtained from a de-escalated regimen is a worthwhile PCR for a patient, that is valid for outcome, and that is independent of further chemotherapy. So Christine, a lot of the patients in the de-escalated TDM1 plus PM had further chemo, but our ADAPT trial, a lot of the patients did not, and we did not see a difference. And again, in Christine, in this de-escalated regimen, we see that ER-positive disease has less PCR than ER-negative disease. Then, and I think our second speaker is probably going to be talking more about this, but I just wanted to point out some of the molecular features that we know that may help us to design these trials further. The molecular subtype in HER2-positive early breast cancer differs according to hormone receptor status. And on the left-hand side, you can see the tumors that are hormone receptor positive, HER2-positive, and you see there is more blue, so there is more luminal molecular subtype and a little bit of HER2-enriched, but there is twice as much HER2-enriched subtype in the hormone receptor-negative population, and that's definitely going to affect outcome under certain therapies. And if you take this a step further, and this is data from Alex Pratt and his colleagues, where they looked at which tumors are actually quite susceptible to anti-HER2 therapy, they found that it's the HER2-enriched subtype, and it's the subtype with the ERB2 mRNA, high mRNA levels. And you can see here, this is the orange cohort in the pie charts, that they are more frequent, much more frequent in the hormone receptor negative than in the hormone receptor positive tumors. And this subtype under and de-escalated anti-HER2 therapy is therapeutically relevant. Then Alex and his colleagues also looked at the immune markers and how they change, and how this is reflected in the different hormone receptor groups. And what we saw was that the tumor immune contexture, so the makeup of the tumor and the immune system, as well as the inflammation capacity, so what's happening after a few weeks of therapy, that is quite dependent on hormone receptor status. And unfortunately for our session today, the strongest effects here observed in the HER2-enriched and in the hormone receptor-negative tumors. And if you're interested to see how dual HER2 blockade plus pembrolizumab works in HER2-enriched tumors, please come and see our poster discussion by my colleague Sherko Kümmel of the WSG Key-Rich trial. PIK3CA mutation is also a factor that has been implicated with poor response to anti-HER2 therapy, and this is from a nice meta-analysis by Sibyl Leubel and colleagues. And you can see that this, the effect of PIK3CA mutation on anti-HER2 therapy efficacy is most pronounced in the hormone receptor positive population here, and this is also relevant for patient outcome. So for a long time, we thought that this was only true to antibody therapy, but ADCs were different. If you look at the Emilia study, for example, but our study, the WSG ADAPT trial, where we gave 4 cycles of TDM1 as neoadjuvant therapy, we also saw that PIK3CA mutation impacted TDM1 efficacy, where the PCR rate here is only half of that in the mutated tumors versus the wild-type population, and that is true for the TDM1 arms, but also for the trastuzumab arms. So I don't know how that works with more modern ADCs, but for TDM1, definitely in untreated population, PIK3CA is a prognostic or predictive factor. So if you look at trials that have de-escalated and also included hormone receptor positive tumors, there's a lot of work done by the Baylor group and published here by Rimavi and colleagues. And what we've learned is that in the hormone receptor positive population, you have more PCRs after longer therapy. And there is also more almost PCRs like the YPT1As and Bs than in a hormone receptor negative population, and there's less of these near PCRs after longer therapy, and I think this is very important if we think about future trial designs. What we saw when we did the ADAPT trials, looking specifically at hormone receptor positive and hormone receptor negative populations, this is from the ADAPT hormone receptor positive, HER2 positive trial with 4 cycles of TDM1 plus minus endocrine therapy. We saw that you can obtain quite a substantial PCR rate of over 40% just by 4 cycles of TDM1, hardly any side effects, wonderful regimen and 40% PCRs, and we could show that PCR matters. PCR is quite prognostically relevant, and it's the key determinant of survival, and whether patients had more standard chemotherapy after surgery or so did not matter here. So this is a good way to move forward. If we have a PCR on a de-escalated regimen, we can trust this PCR if you want. What we also learned was, again, that we see about 10% of near PCRs. We see some DCIS on top of that. So this is very interesting. And we also saw, and I think that was important also for future trials like Catherine, that endocrine therapy did not impact TDM1 efficacy. It did not do so in postmenopausal, but neither in premenopausal patients. What we also looked at was early response. We tried to take a biopsy after only 1 cycle of TDM1 plus minus endocrine therapy or trastuzumab plus endocrine therapy, and we did see that this early response, either by Ki67 drop or low cellularity, was prognostically relevant. But what we also saw was in about a fifth of the tumors, there wasn't any tumor tissue left after only 1 cycle of therapy. And Alex Pratt and his colleagues could also show this with the molecular assays, that at week 2 there was half of the tumors had this normal-like subtype, which was correlated with higher PCR and lower cellularity. So this is a very, very quick response. So if we trust these tissue-based early response assessment, this may not be good, because we're missing out on a lot of these complete responders after very short therapy already. Another way was done by our Italian colleagues in the Periliza study, where they took the hormone receptor positive, HER2 positive tumors and looked at endocrine efficacy with this 2-week aromatase inhibitor therapy, and then the molecular responders could go on to have endocrine therapy plus dual HER2 blockade, whereas the others got paclitaxel plus dual HER2 blockade. And you see here in these endocrine responders, you have more luminal tumors, but the HER2 enriched subtype is the predictor for outcome in both groups, the molecular responders as well as the non-responders. Please allow me to deviate a little, just 2 slides from our hormone receptor negative HER2 positive trial, where we gave paclitaxel plus dual blockade versus dual blockade alone. And this is the arm with just dual HER2 blockade. And I just want to show you how important it is, in my opinion, to select these patients for these chemotherapy-free regimens. We shouldn't do this in all comers anymore. We've learned enough that that is not really appropriate. So if you take the basal-likes, for example, they had 0% PCR. If you take the ones with HER2 2+ FISH positive, they also had very few PCRs, and the non-early responders also did not have so many PCRs. So we have about a third of the population of these all-comers is non-sensitive, and that is clinically relevant because they don't do so well after all. So I think if you want to go chemotherapy-free, we have to pre-select. And going back to the triple positive with the TDM1, another point that is important here, you can see most of the tumors had luminal molecular subtype, but the highest PCRs we saw in the HER2 enriched population, but the best outcome was in the luminal A. So if we want to de-escalate in triple positive disease, it's not enough just to look for PCR. We have to have outcome data in order to make sure that these patients actually do well. And the last example for de-escalation is the Fergain study with the early response assessment by PET-CT, and patients could have a dual HER2 blockade plus endocrine therapy if they were hormone receptor positive, or chemotherapy, TCHP, and then there was a response assessment by PET-CT after 2 cycles, and you see the majority of patients did respond well in the antibody alone arm, and interestingly, those patients who did not have an early response had a lower PCR, but this effect was more pronounced in the chemotherapy group. And if you look again at the hormone receptor status, you can see also in this de-escalation trial, the orange ones, the dark orange ones are the hormone receptor positives, and they're just lower PCR rates in all of the arms. So I think by all of these trials where we try to de-escalate by just using a chemotherapy-free HER2-directed regimen, the PCR rates we have achieved are not comparable to the ones that we do with de-escalated chemotherapy. And this is the last approach that has been sort of deliberated internationally, is just to take de-escalated chemo, 12 weeks of paclitaxel plus dual HER2 blockade, and then go further by individualizing therapy based on that response. And what kind of PCR rates can we expect? This is from the ADAPT hormone receptor negative. We see 90% PCR after this de-escalated regimen, and in the ADAPT triple positive 2 with pacli weekly plus dual HER2 blockade versus antibodies just with endocrine therapy, we have 56% total PCR. So this is quite high numbers, and I think this is, for some patients, this is optimal therapy, and we don't have to do any more. And this is exactly what our US colleagues are doing currently when they are looking in the COMPASS HER2 PCR trial, where they do this induction chemo with paclitaxel or another taxane, 12 weeks plus dual HER2 blockade, and then they de-escalate or escalate based on PCR status. And I think this is a very straight way forward, which may end up in the clinic pretty soon. So with regard to the current developments in the individualization, I think we have enough, not enough, but a lot of trials going on addressing escalation and de-escalation. And the escalation approaches are in the non-PCR patients, but unfortunately not very many trials looking specifically at the hormone receptor positive cohort. So we're underusing the properties of hormone receptor positive disease here in the escalation, and the only trial that's out there internationally on a larger level is the eMonarch with the abemaciclib. De-escalation approaches, we have a lot. They're based on either early response after induction chemo, COMPASS HER2, de-crescendo, that's in hormone receptor negative, but similar principle, or on treatment assessment like ADAPT, PERLYSA, or the Fergain study. And just remember, if you do something on treatment assessment, the tissue-based approaches are impaired by rapid response. So the ones where you can't evaluate the biomarker because there is already no tumor tissue left, these are patients that actually do very well afterwards. And then we can do biomarker enrichment, and that would enable to omit systemic therapy, and promising candidates would be PIK3CA or molecular subtypes at the moment. So in summary, how can we move forward? I think in the looking at the high survival rates that we have obtained so far with chemotherapy and HER2-targeted therapies, therapy individualization is quite reasonable in order to maintain the benefit while reducing short and long-term side effects. We've been doing this in luminal breast cancer. Why not do this in HER2-positive as well? And the first generation of de-escalation trials, just as ADAPT or Christine have demonstrated these trials are actually feasible, they're safe, and they do benefit the patients that are on the trials already. And PCR achieved by a de-escalated regimen is clinically relevant for patient outcome, even without further systemic chemotherapy. And the neoadjuvant concept actually offers a very good basis for therapy individualization. So specifically in hormone receptor positive, HER2 positive early breast cancer, the trials need to take advantage of the hormone receptor positive disease properties, and I think we'll hear some of these in the second talk, and the tumor biology, but also the additional therapy approaches that we have here. And they need to be sufficiently powered, but also incorporate the survival endpoints, because luminal disease has less PCR, but still very, very good outcome. But lastly, I think we should make sure that all of our attempts to de-escalate therapy should be evidence-based and not gut-felt oncology, because we have achieved very, very good outcomes so far, and we just don't want to throw out the baby with the bathwater. So what are the potential strategies, and what kind of questions can we ask? I think the upper one is the induction chemo, 12 weeks Paclitaxel or other taxane and dual HER2 blockade, and then after PCR, I think we can ask the type and the duration of the anti-HER2 therapy. If you have a non-PCR, we should ask what kind of standard therapy do these patients actually need, and we may even verify non-PCR by a core biopsy and then still go on in the neoadjuvant setting to see how patients respond to this standard therapy. And then obviously the type of anti-HER2 therapy, and we talked about the escalation approaches that are ongoing internationally. The other way you can go, if you want to do chemotherapy-free, just anti-HER2 therapy plus endocrine-based therapy, I think we need to pre-select the highly HER2-positive tumors by immunohistochemistry, HER2-enriched, PIK3CA wild-type, and maybe other markers in the future that could help us there. And there we need to look at how long do we need to treat and what kind of therapy. Should we add maybe also CDK4/6 inhibitors in this neoadjuvant phase, not just experiment with the anti-HER2 therapy, and the early response assessments are quite important here. And then after PCR, I think we shouldn't change too many parameters. Maybe standard anti-HER2 therapy is safe for these patients. And then obviously in hormone receptor positive disease, looking at PCR is not enough. We also have to look at patients' outcome. And with that, I would just like to close, and I'm looking forward to your questions. Thank you very much.
I'm not seeing any questions, so I think we should move on.